The title today is Meeting Challenges in Ovarian Stimulation. We have three experts today, and let me introduce you to the experts. Dr. Suresh Nair is an ONG doctor at the Seed of Life Fertility and Women's Care Medical Center at Mount Elizabeth Novena Hospital, Singapore. His areas of subspecialties are in reproductive endocrinology, infertility, and assisted reproductive techniques. Dr. Nair has also had extensive experiences in minimal access endoscopic and robotic reproductive surgeries. Dr. Nair has served as a medical director in 3 fertility centers in Singapore and is currently the medical director of Monash IVF and the chairman of the reproductive medicine section of the College of ONG in Singapore. Our second panelist is Professor Dr. Prasanna Subramaniam. He's a consultant ONG and fertility specialist and a minimal invasive gynecological surgeon who is currently practicing in Thomson Hospital, Kota Damansara, Malaysia. He obtained his medical degree from the University of Manchester, UK, and went on to complete his postgraduate and subspecialty training in Oxford, UK. Prior to his role in Thomson, he was a consultant gynecological and endometriosis surgeon specializing in fertility and endometriosis care at the Oxford University Hospitals, UK. His academic work has seen him earn multiple prestigious awards, including the nomination for British Fertility Young Clinician Award for 3 consecutive years. And our third panelist is Dr. Lisa Lingping. She's a consultant ONG and reproductive medicine specialist at TMC Fertility Center in Ipoh and Penang, Malaysia. She obtained a specialist qualification in Masters of ONG from University of Malaya in 2007. From then on, in 2012, she pursued subspecialty training in reproductive medicine under Ministry of Health, and in 2013, a fellowship training in reproductive endocrinology and fertility in KK IVF Center in Singapore. And she's a gazetted reproductive medicine specialist since 2015. A bit of housekeeping rules. Please, if you have any questions, kindly type it out in the Q&A box above, and we will try to address all the questions in this session today. So without further ado, let's go on to our session. So the first case, let's click this one. Okay, good. The first case today that we're going to discuss is a 33-year-old lady with a 38-year-old husband who's married for 3 years. They've been trying to conceive for 2 years, regular cycles, no dysmenorrhea, non-smokers, but BMI on the higher side, 37, and the husband has triple defect. Her past history in June 2023, during a regular gynecological follow-up, noted to have a thickened lining. And so a hysteroscopy and polypectomy was done, where she was noted to have endometrial hyperplasia without atypia, treated with MPA for 6 months. Then they repeated the sample, which was normal 6 months later. She underwent an IUI cycle. Unfortunately, it failed. They'd given her FSH injections and estradiol tablets to thicken the lining. So she's been on quite a lot of supplements: Q10, 300, folic acid, omega-3 fish oils, metformin, multivitamins. And the first IVF was done in March 2024, where the doctor mentioned she had 15 antral follicle counts and AMH was about 11. So minimal stimulation was done. 150 HMG was given every alternate days. She had 8 follicles. They managed to retrieve 4, 1 matured, and it developed to day 3. She did a medicated frozen embryo transfer. Unfortunately, it failed. So she came in for a second opinion. At that time, she had 18 antral follicle count, and AMH was about 14 picomole per liter. So her blood tests were unremarkable. Everything was quite normal. Thyroid functions, infection screening, AMH, about 14, everything was fine. So the doctor decided to give a higher dose this time. In view of her BMI and previous outcome, they've given her FSH 300 and HMG 150 injection units, and triggered with triptorelin 0.2 milligram. So this was how the stimulation went on. So for 5 days, 300 of FSH, 75 of HMGs, and then this was a response. Subsequently, the stimulation was continued, and until she reached adequate size, and then a retrieval was done. So this was the post-retrieval report, where 14 eggs were collected, 7 usable, 7 fertilized, 7 eventually developed, but only 1 was managed to be frozen. And the husband's sperms had the triple defect, where his concentration was low, motility was low, and morphology only 1%. So she had only 1 egg frozen, which was BG3BB. So this was how the time-lapse video looked like. This was the embryo, which eventually was frozen. This was the BG3BB. And the rest of the embryos arrested. This was the BG3BB and frozen. And this was another blastocyst, which was BG4 CB, yes, and which was discarded because it was of poor quality. So the issue here is about poor quality oocytes. So her next plan is to repeat the IVF cycle. So I'd like to open it to the panelists. How would you like to treat this patient? So let's beginning with the initial phase. How would you prepare her for a next stimulation? Dr. Prasanna, I'd like to answer the question first. You're muted.
So I think pre IVF optimization could be employed in this scenario. I think we're already using quite a few multivitamins, coenzyme Q10 and metformin for someone like this. Something I'd like to explore with her would be a weight reduction agent for a short while, such as liraglutide, to improve her overall BMI, because this not only will improve her IVF outcome, but it will also improve her early pregnancy and obstetric outcome. Alongside that, I would like to see whether, I know she's already on a 1,000 milligrams of metformin, whether she would tolerate a slightly higher dose of metformin. Again, that would be quite helpful to know the side effects, if that was the reason to why she was on 1,000 milligrams rather than 1,500 milligrams.
And how about Dr. Suresh? What would you add for stimulation?
Yes, I think I would concur with Prasanna regarding the BMI. We all know that the consumption of the gonadotrophins and how one responds in a high BMI is often diminishes the overall outcome. It looks to me that she is in the category of the Poseidon 1 group, good image and androgen follicle count, young, and yet not performing. It's not even producing the number of eggs we expected to do so. Yeah. Also, there's a significant male factor. So I would tend to investigate, get my urologist on board, do a scrotal scan, see if there's a varicocele. We might want to work along those lines as well to optimize, as you rightly pointed out, Prasanna, and I'm sure both of you would agree, that we have to get the gametes in good order. Whether you believe in using antioxidants, I'm a strong proponent of that, is something we must seriously consider. With regard to weight reduction, yes, even if it takes a few months, I think it goes a long way to have a greater efficacy of any of the gonadotrophins you might use. Now, whether you want to use gonadotrophins that have been promoted as those that are specific to the individual, for example, some of the Delta formulations where it's been put forth as an algorithm based on AMH and body weight. You could use that, but I do feel that in this instance, adding on luteinizing hormones has been done, as shown before, rather than the highly purified menopausal gonadotrophins may be the better of the two. We know there's mounting data to suggest that pure LH or LH presented in a FSH LH 2-to-1 combination has performed superior to the other formulations. And I believe that some of you might have some experience in that in comparison, and maybe you might want to talk about that later. I really think that we should pursue the sperm factor issue quite vehemently, because often that is downplayed and not properly addressed. And so that's one area. And whether in the lab we want to use piezo, ICSI, I will talk to my colleague, my embryologist, how else can we improve my fertilization rates and performance? Do I consider calcium activation of the oocyte? Now, all of these are just components of care that we know, but what is the science behind it? Will it really prove to be valuable in this couple? That's hard to configure, but these are some of the things that come to mind for me, at least.
Thank you. How about Dr. Lisa? What do you think about the synchronization of the follicles? How would you like to achieve synchronization if you can?
Yeah, because when you look at the stimulation protocol, it looks like your leading follicles are a few, and from the retrieval, you retrieve 14, but the usable ones are only 7, about half of it. So I believe there's some asynchronous in the growth of the follicles. So probably in her next cycle, by doing some pre-treatment prior to the her next stimulation might help in synchronicity of the follicle growth. I would actually try her out with estradiol priming prior to her stimulation. We need to start it in the mid luteal phase and stop it following her menstrual flow. That's also one option that can be done. Else, a change in the protocol, because this is actually an antagonist protocol. Probably you want to try other protocols such as the long agonist, which will also help work well for the asynchronous growth.
How about the option of using progesterone, prime ovarian stimulation for this patient?
I think in situations where there's asynchrony ab initio, let's say we are starting at a 12 on day 2, using the PPOS protocol might protect you from a inadvertent LH surge without unnecessarily suppressing the growth of the follicles. It's easy to use. You can start ab initio. I think Prasanna, Lisa, you might have some experience in that. Would you like to share your experience in the PPOS protocols?
I've used a PPOS protocol for times, and I do find that they are actually quite easy. It means it's very patient friendly, and find the follicle growth quite synchronous. And for my cases, right, I don't really get so many asynchronous growth. But with PPOS protocol, the patient must be very, very careful, meaning that because they don't have injections with them, they're given some oral progestogens, they have to be reminded that they have to take the progestogens every day, and if possible around the same time. So it's the one thing important on PPOS protocol.
Yeah, I would concur with that, because we've had instances where patients, because it's the least costly, as it were, and at least involved administration, they might inadvertently tend to forget it. That's why in our clinic we are quite emphatic about that. What about you, Navdeep, yourself, and Prasanna? What is your take on this?
Well, the progesterone protocol, definitely it's good, and I think the outcome has been in our center has been comparable with the antagonist protocol. And one thing for sure, a lot of patients like it because they reduce the number of injections that they're required to take. So you just remove the entire antagonist injections. And secondly, of course, as I mentioned, we do get a good synchrony of growth of the eggs, and I mentioned the outcome is actually quite comparable. So
Yeah.
yes, I think it's something which, especially for patients who are fearful of injections, now that's a good protocol. So you help them reduce the number of jabs.
But coming back to this case, as such, I think asynchrony, a combination of estrogen priming, and sometimes we all know that in spite of estrogen priming, you have that escape phenomenon nevertheless. And having the PPOS protocol might help. But one of the other things maybe we might want to consider here in our next cycle, and I believe, Prasanna, you have experience in this dual stimulation, where the initial follicular phase is your or rather cycle-induced synchronization. Your estrogen levels will be high, your progesterone levels will be high. And a few days later, after your OPU, you find a very synchronous andro follicles. But in situations where there are many corpora lutea, I must admit it's challenging, and you can just start off. You need not necessarily do a scan. You can start off with the first 5 days of stimulation, even in the PPOS, and then take it from there. What do you think, Prasanna? In this instance, especially, because this is a case where I believe we want to optimize on the number of eggs we can get in the shortest period of time. And so one of the ways to do that, I presume, is the follicular phase and luteal phase sort of stimulation. Or as Polizos described, you can start in the luteal phase, carry on in the follicular phase retrieval, and actually embryo transfer if you wish to. But no eggs. You see, if we had those small follicles, antral follicles, if you don't go after them for that segment, then it's a 0 egg count. So no eggs, zero-sum game, you see. So what is your experience with this dual stimulation, Prasanna?
So we've used quite a bit of it for fertility preservation, and interestingly found that you had a better outcome with the luteal phase stimulation. I think the difficulty is in the initial start for a clinician who is used to follicular phase stimulations, having scanned at the time of the luteal phase and seeing the corpora lutea. So often in our experience, what we tend to do is we don't scan at the start, just to avoid that confusion and sort of fear of not starting. But realistically, the luteal phase appears to offer a much better outcome, especially when the first outcome has been poor in the follicular phase. And that sits quite well with the sort of random start protocol for follicular waves that show that despite the fact that you've got a follicular wave at the start of a cycle, you could still get it in between cycles for recruitment. And so I think for her, as you said, increasing the number of oocyte, increasing the number of embryos would be the main aim, and a luteal phase would offer a different perspective.
Yeah, and also it's been shown by Ubaldi and later by Vetriali, the Bergwall's theory of multiple waves of follicular genesis, of follicles being put out, antral follicles being put out. But I just want to tell you, because we've been doing this for some time now, don't be too disappointed if you find your second phase not performing as well. It is been suggested that you can get better blastulation, higher number of fertilization, but this, at least in our experience, doesn't always hold true. But at least if you can get even one egg or one blastocyst, will be one blastocyst more than 0 if you hadn't had an opportunity to do the dual stimulation. Now, we have even ventured in certain selected cases to what's known as triple stimulation. This was also particularly as you mentioned, in the oncological patients. But this is in an experimental or research protocol. It's not, gone through the robustness of long-term trials and data collection. So in this patient, the way I'm looking at the stimulation, I suppose 300 of FSH is all right. I would tend to use the pure LH formulation and maybe start ab initio with 150. Whether to do PPOS or not, I might make a comparison, one cycle PPOS, and I've even flipped over to antagonist cycles in a dual stimulation and the next stimulation. The patient is their own control, and we can assess, I mean, as she has this multitude of injections and all, and if any of you want to bring up the potential benefit, again, hard to prove, of maybe using growth hormone, there'll be one other injection, and maybe in that cycle you want to do PPOS. You see, part and parcel of management of patient is also all the multitude of things that needs her to adhere to, and compliance, I believe, is sometimes challenged. You see, when we inundate them with so many different methods of administration, a multitude of drugs. So herein, I feel that I am a strong believer of the pure LH formulation, whether you want to use it in a combined cartridge of 2:1 or use it separately. I don't think there's much of a difference, except additional injection. And that might be the way to go, but I really think we should emphasize on the sperm quality. I think, subjecting the poor girl to a multitude of cycles without addressing that, I think all of us, the whole panel, would agree that that must be not forgotten. Yeah.
Yes. Interestingly, you mentioned about the growth hormone. So when would you start the growth hormone? Prior to the stimulation cycle or during the stimulation cycle? I know there are no guidelines about it. So what's your opinion?
As the name implies, growth hormone, the suggestion is it takes a period of time for it to act intra-ovarian physiology. So I'm not a believer of using mega doses of growth hormone only in the treatment cycle within the stimulation. I don't think that works. So we build it up. I tend to use anywhere between 6 and 8 units. Don't ask me why I use this, because this is the work produced by the people who first used it in the world, the pivot group in Perth. And then I think that's the dose they use, and then I'll maybe increase it to 12 units intra-cycle, but I'll drop it down for 2 reasons, or rather the main reason being cost, and maybe maintaining the momentum, but not cutting it off entirely. Now, is this all science? Honestly, no. Is it gut feel? I must admit, yes. So growth hormone, some of my colleagues totally disbelieve that. Some of my colleagues will give it to everybody that walks through their doors. So the jury is still out. I have no hard data. The Cochrane reviews have shown some benefit to some patients. More research is needed. And haven't we always heard these 3 lines in everything that we do? So I use growth hormone, if you want my honest answer, when I'm desperate. Okay, I'm not making any headway. I'll talk to my patients. I tell her quite frankly, I don't think this is something that I have hard data to prove that it'll work all the time. Others will use it all the time, but it has helped maybe. And you all know the work by, I forget the name of the doctor, cycle for cycle, there's variation, variation even in the same individual,
How about Dr. Prasanna, Dr. Lisa? Have you all used growth hormones before? Lisa can start first.
I've had experience using growth hormone multiple times. Like I do agree with Suresh. This is when we are desperate to see some difference in patient's response. Normally, I wouldn't put it as the first line, and it is like an add-on with a hope that we will be able to get some better quality blastocysts. So I used to use it a lot, but then I also do not really find lots of benefits from the patient. So now I'm more cautious of using it.
Let's see. How about Dr. Prasanna? Your experience with growth hormones?
I have to say I've got no experience with growth hormone, purely because the HFEA traffic light system makes it a red drug as an
Yeah.
add-on.
Yes, you're right.
Okay.
We don't use it.
Understand.
Okay.
So,
Yeah.
Mm.
Okay. Now let's go on to the next case.
Before that, Navdeep, can I just put another spanner in the works?
Yes.
Would you all care to maybe give your opinions about maybe the use of letrozole in this patient, let's say?
Mm.
High doses, low doses, continuous right through. What do you think? I mean, it's readily available, at least in both our countries,
I usually use letrozole for minimal stimulation or mild stimulation, IVFs, but not really for these type of patients. But what's your view, Dr. Prasanna?
So I think with someone with a relatively good ovarian reserve, I would not use letrozole as a add-on without the history of endometriosis generally. Speaking, unless cost is an issue and I'm trying to reduce the overall FSH dosing. And that's the only scenario in this particular case I would probably consider letrozole if I want to drop the FSH dosing.
Well, Dr. Lisa?
I don't normally use letrozole for this patient with presumably gluconeosis. I will actually probably change the type of gonadotropins for her in the next cycle. Yeah, I don't
The
include
reason, the reason why I bring this up is Polydor was discussing in one of his previous webinars that you use in those women who appear to have some FSH receptor maybe resistance, whether it's truly genetic or not. You might want to induce the production of the endogenous FSH to see whether it gives you a better response, I mean, that's another angle to look at.
Okay, thank you very much. I think we go on to the next case. The second case is a 33-year-old wife, 35-year-old husband, married 4 years, trying 4 years, been having regular cycles, no dysmenorrhea, non-smokers, and BMI normal, and the sperm had mild teratozoospermia, about 2% morphology. She had history of bilateral cystectomy for endometriotic cysts, and then IVF once before, and in that cycle, she failed 3 rounds of the frozen embryo transfer. So she came in for a second opinion. At this time, her antral follicle count was 8. And the AMH was 4.5 picomole per liter. Her blood test was done, which was quite normal. So she did a second round again with FSH 300, HMG 150. And since her number of follicles were low, we had given her dual trigger with triptorelin and the Hucol. It's HCG. But this is how her stimulation protocol looked like. The first scan, she had 5 follicles, and on the right and 4 on the left, and all quite small. And subsequently, she had 21, 17, 15 on the right, and only 21 on the left-hand side. So the doctors decided to retrieve the eggs. On the day of trigger injection, her estradiol level was 3,000 picomole per liter, and progesterone was normal 2.4. So the retrieval was done, 7 follicles retrieved, 6 were usable, 4 fertilized, 4 developed, but unfortunately, none of the eggs developed to blastocyst. And the sperm volume was normal except for the morphology, 2%. So basically here too, the issue was poor quality oocyte. And so what's your opinion on this patient? How would you manage her differently, Dr. Prasanna?
So I think someone like this with a history of endometriosis, previous surgery, and now low ovarian reserve, low response overall, is slightly tricky for various reasons. The dosing appears to be okay. She's been on a high dose start, and she appeared to have recruited relatively okay. I would consider in someone like this letrozole as a different protocol. So I would probably consider letrozole at the start of the cycle for 2 days prior to starting gonadotrophins, either recombinant alone or recombinant and HMG. I also have had quite good experience with endometriosis patients who've had recombinant FSH and recombinant LH as a single injection. So perhaps rather than recombinant FSH and urinary FSH LH, to use letrozole and the recombinant FSH and LH. And the second thing would be to ensure that there is a lag between the start of the letrozole and the start of the recombinant or gonadotrophins, so a minimum 48-hour lag. And I would also consider continuing the letrozole throughout the stimulation cycle until the pickup appears to have a much better effect in terms of overall response.
Okay, how about Dr. Lisa? What's your take on this? I'm sorry, before that, dear participants, you can type in your questions at the Q&A chat box. Thanks. Sorry, Dr. Lisa.
So she does have endometriosis. So I would like to know whether how, I would like to really know how active endometriosis is, because if,
Yeah.
no doubt that this is the antagonist protocol, and we know that a woman with endometriosis, the study shows that if they do antagonist protocol or long protocol, there may not be much different. But for her next step, probably she do a long down regulation for her, just to see whether it will actually give her some benefits. And yeah, for the antagonist, for the gonadotrophins, probably I will switch her to recombinant 2-to-1 for both the FSH and LH, to see whether it will actually give her some benefits. Probably not so much of a high dose. Whether I will probably start with a lower dose of 300 to 350 instead of 450. Because her AMH is really low. I don't see a reason to push her so high with such high dose. She's only giving us that few follicles.
How about any adjuvant therapy or any pre-treatment you would like to give Dr. Suresh? What do you think?
A good question, Damdip, but before, when I look at this case, I can't help thinking that before all of this, we should not find ourselves in this position, if you know what I mean. You see, ab initio, I think the message we all want to put across today, at least in this case, what is demonstrated in this case, is when you have bilateral endometriotic cysts, lower than 3 centimeters are now best left alone, but anything beyond that, please liaise with one of your fertility experts. Think and counsel the patient about preemptive assisted reproductive technologies. You at least have to do the counseling. If the patient doesn't want to, that's another thing. You have to be very clear and definite about the impact, even by the best of surgeons, even if you do robotic surgery, of the damaging effects upon the human ovary. All you need is to hit one of the hilar end arteries. These are end arteries, and it's gone. Okay, so she might have had a higher AMH and it's now crashed, and we all have been there. All right, so that's a message I think all of us want to put across. Try to give the proper counseling, engage your partners in fertility, and you can continue to do the surgery at a later time, possibly, but at least this has to be done. So that's one thing, okay? You see, this is a girl where her chronological age is young, but her biological age, in fact, in these two patients, is different. They're not behaving as a young woman should do. I mean, at least reproductively. So coming down to this area, I just want to emphasize there are myriad of ways of how you can retrieve stimulation. Your IVF practitioners will help you with that. And we have methodologies where we can retrieve the eggs even if it's on top of the ovarian cyst. We have done transabdominal, either abdominal scan or transvaginal scans to retrieve the eggs as well. So we will do the utmost. So I think engage, okay? I think we have to work together on this. Now, if we find ourselves in a situation of a low AMH, then once again, we have to pull all our forces, scientific background, backing or not. Letrozole is excellent. And agonist cycles, excellent, sure. But to put her through the stimulation and counsel her and support her through multiple stimulation as it must be, and retrieving as many eggs in the shortest passage of time possible. And please understand that the human ovary is a very resilient organ. You don't need to rest in between. This rest phase, you're just going to lose your AMH. So if you are a believer of dual stimulation, go ahead to do the dual stimulation. If you feel one cycle and the next cycle back to back by stimulation is something you want to do, go ahead and do that, because the ovary is resilient enough to, if you do stimulations back to back from January, February, March, and April, it is not detrimental. Okay, you are going to get a higher egg count in the hope of pushing forth enough blastocysts. And then the preparation of the uterus, if say inadequate surgery has been done when the cysts were taken off, and Dr. Prasanna is one of the leading experts in endometriosis, he will tell you that even retrovaginal lateral pelvic wall endometriosis exerts a profound effect on the carriage of the pregnancy. In fact, there's a recent study in 2018 where the Americans have shown that we all know that it impacts on egg count and fertility, but did we know whether it impacts on miscarriages? That it does. Even if the patient doesn't have significant adenomyosis, just regular endometriosis, they're shown with euploid embryos, one wing where they cleared the endometriosis, the other group that they did not clear the endometriosis. Those who had endometriosis did poorly, significantly poorly. And of course, needless to say, if you have adenomyosis as another burden, it makes things even worse. Okay, so then maybe lies the use of GNH analogs to use for a longer period of time to sort of shrink down the adenomyosis. I'm not a strong believer of wedge resections. I think our technique is quite poor. Whether you do it robotically or not, uterine rupture is a high risk. Now, going back to the first instance of the two endometriotic cysts, if one wants to even go back to what Donez has said decades ago, a two-stage procedure. Unfortunately, most of our healthcare, insurance schemes don't support it. You could do the drainage, clear the endometriosis that is around it, come back after 4 months of GnRH analogs, ablate, and maybe stimulate if you wish. That's also a reasonable thing to do.
Yeah. So, what's your opinion on like sclerotherapy, for example, Dr. Prasanna?
So for these kind of patients, particularly fertility patients with endometriomas, if the endometrioma is larger, as Dr. Suresh kindly pointed out, larger than 3 centimeters, causing problems, or to consider two-stage therapy, the sclerotherapy has got good outcome. It has no downside to the ovarian reserve, and it has a similar recurrence rate to drainage, so 30% recurrence rate. So in these patients, we, in our experience, have done a lot of sclerotherapy for them with good effect, without effect to the ovarian reserve. So what we tend to do is a very short laparoscopy, do the sclerotherapy, and shortly after do the IVF cycle to collect the eggs. Then once we've collected and frozen the good quality blastocysts, come back to clear the rectovaginal endometriosis. Because after the experience of clearance of deep endometriosis, we find that the pregnancy rates are much better. But therein lies two issues. One is the recognition that ovarian endometriomas are highly associated with deep endometriosis, and therefore just a cystectomy doesn't solve the problem. Leaving rectovaginal deep endometriosis behind has got multiple negative impact to the overall environment, the fertility environment.
What would you use for the sclerotherapy?
So we tend to use 96% ethanol. There is a volume calculator that you can use of how much ethanol to fill into the cyst capsule. So the easiest way to explain it would be a laparoscopy. We make a small incision on the top of the cyst wall, put a urinary catheter in, wash out the cyst until it's clear, and then put a urinary catheter in, fill the urinary catheter balloon so you've got a tight seal, and then fill the ethanol into the cyst wall, leave it for 10 minutes, and that should do.
Dr. Prasanna, I think your description is a safer methodology, in spite of the fact that it's somewhat more invasive than a transvaginal approach, because I've seen the transvaginal approach where they squirted in ethanol, it leaked all over the place and caused quite massive damage, and it was also quite difficult to control its impact on the other organs. And in that vein, if one is to retrieve eggs, I remember a lecture by Santuruli. I must say I was concerned about the passage of the egg oocyte needle through and through multiple times through a intact endometriotic cyst. That is something I think one has to be very guarded about, should never do, because you can easily get an abscess. This is a rich medium, and in spite of using antibiotics, in spite of cleansing the vagina as much as you want, germs can get in there and proliferate, and you can ruin her pelvis and her reproductive performance, let alone getting her into septicemia. And these are reported cases, okay? So I just want to, another message, I think all of us as IVF practitioners have been called to attend to is this concern about infections. And rare and as it may be, but something's rare and catastrophic is something that you need to be careful about.
How about progesterone primed ovarian stimulation? Would you prefer to use this in patient with endometriosis?
Yes, I think there is a good number of studies that have been done with PPOS, particularly with Visane on board. Visane on board cycles are like your PPOS cycles. So in a lot of my endometriosis cases, especially those with a lot of pain, they have already been on Visane. You can start your stimulation at any time in the cycle. So let's say this girl has been on Visane for 4 months. December 1st, I can just start her on gonadotropins and get eggs and still continue. Yes, there's a little bit of elevation of her estrogens. She might respond to it, but you can still continue to do your IVF, collect your eggs, and proceed as per normal. This is like a PPOS with Visane kind of picture. So there's a lot of data published on that, and quite robust data, I must say.
That's quite interesting. What do you think, Dr. Prasanna?
Yeah, I think downregulation with progesterone from a endometriosis point of view makes scientific sense. I think it will probably, and at least the data shows that it's beneficial. And from a cost point of view as well, it's patient friendly and it's cost friendly to the patient who otherwise would be on longer term agonists, which again can be an injection, can be implant.
The other thing about this patient who has low AMH, how would you like pre-treat them? About let's talk about supplements first. Q10, DHEA, because now there's a big trend that everyone wants to be on Q10 and DHEA to so-called improve their overall outcome. So, what's your opinion on that, Dr. Prasanna?
So Q10, I think definitely I've had very good results with Q10. So I try and have a minimum requirement of Q10 for low ovarian reserve patients with other fertility issues such as endometriosis or increasing maternal age and increasing BMI. In terms of DHEA, the world is split. I'm sure it depends where you are in the low ovarian reserve and how much you're using it for. But again, someone like this who's already had one stimulation cycle, poor outcome, DHEA at the very least will be equivocal. So I'd offer it to the patient as an option, as an add-on option. Now, in one of the experiences, we did use testosterone gel rather than DHEA. And for a short while, we had very good results using testosterone gel in low ovarian reserve. But then after that sort of initial honeymoon phase, it appeared to disappear. So it went back to DHEA. But I suspect that part of which DHEA works is in the same way that letrozole for these patients work, which is increasing intra-ovarian androgen levels. That's one of the theories in which it works. And therefore, I don't see a harm in this scenario to try and improve the ovarian outcome.
How about you, Dr. Suresh? Would you prescribe these add-ons to patients?
Yeah, I think almost all of us do, so that the patient also feels that she's engaged in doing something for herself. I also, I mean, there's no data to back this up, but there's something called French pine bark. It's Dr. Professor Maculia's French pine bark, pycnogenol. Apparently, it's a very potent antioxidant, but there's also too much of a good thing. If you do too much antioxidant, you get into a reductive phase. That too is not a good thing. So I do suggest to couples doing that. But my other strategy would be if I just see 2 or 3 antral follicles, maybe I would use lesser FSH, not because of my belief in minimal stimulation. It's because of the fact that anything higher than that is a waste of money, may not give me extra eggs. But I would surely, in this case, do dual stimulation, and do frequent cycles, as many cycles as I can use, because her AMH is already 4.5. I mean, what if it becomes, and I tend to do my AMH levels every cycle. Some people have the mistaken notion, I've got to say, that one AMH will tell me my ovarian reserve. It fluctuates quite a bit. And if you see a downward spiraling trend, you must up the ante and do all that you can to continue with stimulating and at least justification why you want to propose dual stimulation, why you want to propose the next cycle and go on with multiple back-to-back cycles. So gentle, repeated stimulation is the only way I think we can go, because waiting for months before you do in the presumed sort of notion that I must allow my ovaries to rest is detrimental. That's a definite no-no, because you see the AMH crashing.
Interesting. How about things like ovarian rejuvenation before your stimulation for low AMH? Nowadays we have platelets, PRPs, we have stem cells, exosomes.
Yeah.
What's your take on this, Suresh?
First of all, those are not approved treatment technologies that are allowed in Singapore, because we don't believe, unfortunately, there's robust enough data. But I have a frank discussion with my patients, and I say that I can't do it here, or neither do I maybe feel comfortable doing it. Then I would beckon the help of my colleagues like you, all of you, to help us in that, because you will then do your usual counseling and appropriate advice. And should they want to embark on it, knowing full well that this is, not shown to be categorically, useful in all cases, you might want to embark on it. Some people have suggested PRP, some the Nakamura's Nao Suzuki's methodology of the P450. I can't remember offhand because I don't think it works, but crushing up the ovary and putting a certain form.
Ovarian activation.
Yeah, reactivation.
Yes.
All of this. I think the day we can then retrieve stem cells from the ovary and create not the same chromosomally damaged sort of oocytes, younger oocytes will be great. And
Mm.
if you look even further back, I'm a strong proponent of encouraging, assisting, and helping both financially, psychologically, socially, women to freeze their eggs. I mean, this is one time you should do first and think about it later.
Mm.
And then this whole discussion of, oh, they may not use their eggs. What if, why should most women don't need to use their eggs, they get married? I'm happy with that. Fantastic. So my take on that is I rather have money in the bank, and if I don't use it, I'm happy. If I don't need to use
Mm.
my savings,
Mm.
So I think the whole emphasis, and there's always this argument, why is it women must freeze eggs and we have to make the sacrifice? I suppose it's biology for the time being until we discover another way out. Is biology. And also this whole criticism about the eggs not being used. Do we wait long enough? After 2 years, they are saying none of my patients use the eggs. Of course not. You wait 10 more years, maybe,
Correct.
more people will use it. And also, there's a big segment, those who freeze their eggs, not for fertility, who have just frozen their eggs and they have merrily got 3 children. And she's
Mm.
now 42. Biologically, she is not going to be a reproductive unit, so to speak. But if
Yes.
we have done social engineering, if you were to call it that, and she had frozen her eggs at age 30. This couple are still able to produce babies in countries where our fertility rates are dismally low.
Mm.
So utilization occurs. Sorry, I
Yes.
keep on going on about this, but that's all I got to say about that.
Yeah, I totally agree. I think yes, I mean, egg freezing should be even more prevalent.
Emphatically
Everyone
put,
should
yeah.
do it more because eventually there'll be a certain group of patients which will require to use it. Many women end up getting cysts, undergo surgery, and getting your ovaries damaged, or they want to delay childbearing to a later age. Yes, I totally agree with that concept.
I mean, you see, the typical, you educate a female child all her life to get into a good profession, to get into leadership roles and all that. Something's got to give, right? So you've
Yes.
got to support her and give her every opportunity, every support to freeze her eggs and sort of
Mm.
passionately encourage her to do that, So
Mm.
because that's the only way we are going to reverse our population dynamics now. The pyramid is on its head, And
Yeah.
I think most of our governments have not even begun to realize how serious a problem this is. No point making roads, highways, buildings, and all that when there are no people to inhabit. So I feel very strongly about that because it's a serious problem. It's an existential
Yes.
problem.
Exactly. Yes. So can I make the main question again, Dr. Prasanna? What do you think about all this rejuvenation, PRPs, exosomes, stem cells? Have you had any research done before? Any experience in this?
So I come from an environment where all of these were considered red add-ons, so
Oh.
none of which were allowed. However, I have to say the IVA theory, having worked with CESA, with IVI RMA before, has got some promising results. And the simple way I look at it is going back to the data of women who had failed IVF cycles and then go on to have spontaneous pregnancies. And
Mm.
there is some belief or theory that the ovarian
Functions.
punctures cause a reactivation of the ovarian cell. And that's what Kawamura, as Dr. Suresh kindly pointed out, Kawamura has sort of
Mm.
hypothesized and also shown in his data sets. I mean, these are women with almost no ovarian reserve. They are all POI patients. Of course, the below 40 POI patients or true definition POI patients did much better than the post 40 low ovarian reserve patients who went through IVA activation. But compared to a 5% natural conception rate, they seem to get 25% live birth rate,
Mm.
which in normal terms is pretty good results. But would it be for someone with this history where the ovarian reserve is low but actually do get egg count? Probably not. That's one thing. The second thing is, in terms of the PRP and stem cell, the issue is, and this is with my experience doing ovarian tissue transplantation, it's extremely difficult to separate the cortex and the medulla, even when you're surgically excising it. Therefore, to target the cortex to ensure that the stem cell or the PRP is reaching the cortex to give you the highest amount of concentration, I'm not sure it would be precision enough. And so I believe that there is probably a methodology problem with just the administration, leave alone the process after that.
I see.
Okay, I think there are no questions here today. Q&A. Okay. Oh, I just
There are no questions.
there's a question in both patients. I'm wondering whether there is a role of going above the recommended ceiling of 300, 375, or maybe acceptable, but up to 450 IU, I feel really quite high. Yes, I think we agree. And what do you think of the ovarian stimulation relating to the quality of oocyte? High dose, of course, would it produce poorer oocyte quality? What do you think? High dose with poorer oocyte quality? Dr. Prasanna, you think the high dose cause the poor quality?
So I suppose the first and second question is slightly related, in the sense that again, in the UK we didn't really go above 300, very rarely 375, and a lot of the data about 300 comes from a different population. Having been in Malaysia now and seeing the Malaysian population, I believe that the dosings need to be altered for the Malaysian population. So there is probably a gap in the data for this cohort of patients. That's the first thing. The second thing is, in terms of the overall dosing causing a poorer oocyte quality, I don't believe that it's purely down to the dosing, because most of these patients appear to have other confounding factors that would easily explain the poorer quality.
And the other thing about the second case, you mentioned letrozole. What's your starting dose, and how many days before starting the FSH stimulation would you start your letrozole?
So letrozole, tend to start 5 milligrams once a day, and at least 2 days before the start of FSH. So 2 days of letrozole prior to
Starting.
the FSH.
Yes. Okay, there's another question about how about modified JAP protocol? JAP protocol for low ovarian reserve. Not sure what this means.
Japanese protocol, I think they're talking about a keto protocol where you use either clomiphene or letrozole. I think if you got a couple of antral follicles and both can be grown by using what is referred to as a JAP protocol here, by all means. I mean, the only thing is where you don't have an antagonist, it's quite hard to really know when to trigger. You might have an escape LH surge. So now with PPOS, it is made a bit easier.
Yes. Okay, I think that's about it. I'll thank Dr. Prasanna and Dr. Suresh and Dr. Lisa. And I'd like to thank all the attendees. I hope you benefited from this Aspire web series. Thank you very much.